Okay, so we're going to talk now about preventing some of the musculoskeletal complications. Bone loss is one. We want to have that patient weight bearing as early and as often as possible. So again, getting people out of bed when possible. Muscle atrophy, we want them weight bearing as much as possible. If they're not able to bear weight, we want them doing exercises in bed. Their bed and isometric exercises, because muscles atrophy when they're not used. So if we get them using those muscles, it helps. The same thing for joints. Joints freeze. They get stuck basically, and we have contractures when we're not using them. What happens with the contracture is actually the tendons and ligaments get really tight, and you cannot extend that joint. So we want to prevent contractures with active or passive range of motion. Obviously, active is better, but if the patient cannot do that, we want passive range of motion. So that's how we prevent musculoskeletal complications. I'm going to move on. I'm going to actually move this to a little bit different order, and we're going to talk about preventing falls because that's connected to musculoskeletal. So we really need to prevent patient falls, but we also need to have patients up and moving so they don't lose function. So every patient should be evaluated for fall risk, but one of the things we need to look at for fall prevention is strengthening that patient. If the patient is not able to ambulate with nursing safely, then PT needs to be involved. And realistically, nursing may not be staffed enough to have time to walk people and move them as much as needs to happen. And so PT may need to be involved in that situation as well. We at least want to try to get someone out of bed for meals if they're able to tolerate that whenever possible, because that's going to improve their, that's going to use their muscles some. It's going to help with the orthostatic hypotension. It's going to help maintain some core strength. So we at least want to try to get people out of bed to a chair when they're stable enough to do so, because that's going to help prevent some of that mobility loss. We also need to be aware of correct use of mobility aids. And a lot of people aren't really educated on how to use their mobility aids correctly. Personally, I would prefer a physical therapist do this every single time. But as a nurse, you may be in the position of helping someone learn how to use those correctly. So some basic guidelines, please watch those videos. They're by a PT, they're fantastic. But some basic guidelines: crutches need to be sized appropriately. When they're sized, the armrest of the crutch at the top, that isn't actually a rest. It should not be up in the axilla. It should be a little bit below the axilla. And with that rest below the axilla, the patient needs to be able to have their hands on the hand rest with their elbows slightly bent. And that patient needs to support their body weight on the hand grip with the elbows flexed when they're moving. When they're going up and down stairs with crutches, there are a couple of options. They can actually go to a handrail, and especially if they're partial weight bearing on the injured foot, hold the crutches and go up and down. Down, a lot of times they may hold them to go down. But if they need those crutches to go up and down stairs, they need to understand you always go up with the good leg first, down with the injured or weaker leg first. So always up with the good, down with the bad. Okay. If someone is using a cane, this is another common error. The cane should always be used on the strong side. If they're using a cane and they're holding it on the weak side, if they don't get that cane placed right, it falls out from under them. So the cane is always used on the strong side. The patient supports their body weight on both legs, and they move the weaker leg forward first with the cane, lean on the cane to move their stronger leg forward. So biggest mistake people make is putting the cane on the weak side. The cane goes on the strong side. A quad cane is always going to be more stable than than a single prong cane. If someone is using a walker, we want the walker to be, again, the appropriate height. When their hands are on the hand grips, their elbows should be slightly bent. And we want to teach the patient to move the walker and then move their body so that they are staying with the walker, especially after total hip replacement. Sometimes you'll see patients that move the walker and they barely move their feet, and then they move the walker further. So they end up scooting the walker way ahead of them and they're not moving. So it's not helpful at that point. Okay, so that is some basic stuff about mobility. Please watch those videos about how to use the mobility aids. The final video is going to be about preventing the elimination complications.